Hello, everyone. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us for tonight's webinar on biliary atresia. Liver Health Foundation, as you know, is a California-based entity. Many of the members of our board of directors are either liver patients or representing liver patients or are in the healthcare industry. Liver Health Foundation's Medical Advisory Council, led by Dr. Sami Saab, has over 30 members who are some of the best hepatologists and liver specialists in the United States. We are very proud of our Medical Advisory Council. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host the community and physician-centered educational program. Today's webinar is our last 2022 educational webinar. I have to tell you, 2022 has been a very productive year for us. We have been able to hold over 17 educational webinars and in-person programs and events with the goal of supporting liver patients and providing life-saving and accurate information to them. As we speak, we are posting our 2023 programs and events on our website. For more information, please visit liverhealthfoundations.org. Tonight's program has been made possible by a grant from Albireo Pharma. We thank Albireo for their support of our efforts and hope you find this information helpful. Without the support of our pharma friends, we could have not accomplished as much as we did in 2022. Now I would like to introduce Dr. Christine Clemson, PhD, MSCI, Senior Vice President, Global Head of Medical Affairs at Albireo Pharma. Dr. Clemson leads Albireo's Global Medical Affairs function, which is responsible for ensuring that Albireo is established as a leader in the field of cholestatic liver disease. Some of the key responsibilities for medical affairs includes establishing relationships with clinicians who care for patients with rare diseases such as ALGS, PFAC, and BA, field medical support of the commercial and market access teams, publication, external and internal education, as well as scientific grants funding. Christine spent 20 years in academia studying non-coding RNA at the University of Massachusetts Medical School, where she earned both a PhD in biomedical sciences and a master's in clinical investigation. She then transitioned to pharma in the rare disease space, working and gaining experience in several global pharmaceuticals. Her most recent tenure before Albireo was in women's health, working at Sage Therapeutics, leading the medical team during the launch for the first approved drug for postpartum depression, and at AMAG, where she led the medical support of the women's health franchise. Dr. Clemson, thank you so much for your support and for being here tonight. We are ready for your presentation.
You're muted.
Thanks so much, Sarah, for having us again. Really exciting to be here for the final 2022 workshop. I've attended them all and they've been really educational and informative. So thank you so much for all you do for the community. Welcome patients, caregivers, clinicians. I'm going to briefly describe to you who Albireo is and what we're working on, and specifically a study that's ongoing that recently fully recruited that should read out data in biliary atresia in a few short years. This is the first phase 3 randomized control trial in biliary atresia, and we're really excited and hope that it can bring treatments to children who haven't had treatments before all over the world. Vera, thank you so much for the kind introduction. I'm Christine Clemson. I lead Global Medical Affairs for Albireo. And Albireo is a small biotech company. Our mission has been to provide hope for families. We were founded in 2008, and we have well over 140 employees now currently. And our expertise is in bile acid modulation science. And we focus on rare cholestatic liver diseases. And the reason why we're considered bile acid modulation experts is our drug odevixibat is a bile acid modulator and reduces the burden of bile acids in the liver and in the serum, and then such can effectively treat the diseases we're studying. Biliary atresia is under investigation for us right now, but we do have the product on the market for PFIC. And we're really proud of the studies that we run in these rare diseases. The PEDFIC-1 and PEDFIC-2 program was the first and largest global randomized phase 3 study in PFIC. And on the basis of this data, we received approval in PFIC about 2 years ago in the US and Europe. We've just recently reported data on our Alagilles study, which completed enrollment earlier this year, and positive phase 3 data, and we're actively filing with the EMA and the FDA, and we hope to have odevixibat for families with Alagille syndrome in the US and Europe sometime next year. We're here to talk about biliary atresia, and our biliary atresia study is called the BOLD study. And as I said, it's the first fully enrolled global randomized placebo-controlled phase 3 study in biliary atresia patients. So these are the 3 areas we're most currently interested in. And today we're going to be talking about biliary atresia. And I really won't go into the detail on the disease because we have Dr. Yanni to talk to us about that today. But what I want to focus on is the serum bile acid elevations that occur in these children and that can potentially portend liver disease progression. And so modulating serum bile acids through odevixibat or Bylvay is what we're studying in our biliary atresia study. As I said, we aim to be a cholestatic liver disease company across the board. And these first 3 indications we've talked about, PFIC we're already approved for, Alagilles we hope to get approval next year, and biliary atresia we hope to get approval in the next 2.5 years or so. We also have other compounds in the bile acid modulation space, and some of those will be in viral and cholestatic diseases, as well as adult liver diseases. I should point out, however, odevixibat was our first compound ever approved, and it's approved in Japan and Thailand for chronic constipation. So the BOLD study, explained here, is, as I said, a phase 3 study where we aimed to recruit 200 subjects who had already had a Kasai surgery. We were fortunate to over-enroll. There are 205 subjects that are enrolled, and so the study is no longer accepting new patients. The key inclusion criteria was a clinical diagnosis of biliary atresia, and you couldn't have the surgery, the Kasai surgery had to be performed within 90 days. And the randomization, 90 days of birth, and then the randomization occurred within 3 weeks of the Kasai procedure. It's a randomized double-blind placebo-controlled study, and the patients were randomized either to 120 microgram per kilogram per day dose or placebo. And the primary endpoint is what they call a very hard endpoint. It's the proportion of patients who are alive and have not undergone a liver transplant at the end of the study. And given this is an ultra rare disease, we've had good access to the FDA and EMA, and they've made it very clear that the data from this study would be suitable for a pivotal, would be considered pivotal and would be sufficient to support a filing. We have patients enrolled in 58 sites around the world. So the purpose of the study is to compare the efficacy and safety of odevixibat, which is an orally administered selective inhibitor of the ileal bile acid transporter, compared to the placebo in children with biliary atresia who've undergone a Kasai procedure. We started in July 2020. Not really the greatest time to start a clinical study given the pandemic, but we really had great engagements from our clinicians and the site staff and the patients and caregivers. And we're happy to have enrolled in November of this year fully. So as I said, this is a hard endpoint. It will be, the primary outcome measure will be the percent of patients who have survived with their native liver after 104 weeks of treatment. All sorts of other things we're looking at, like sentinel events, including significant ascites, bleeding, liver transplant, death, and time to end-stage liver disease, total bilirubin levels and serum bile acid levels, as well as, of course, adverse events, serious adverse events, and all sorts of laboratory parameters. The inclusion criteria was males and females with a clinical diagnosis of biliary atresia. And again, they had to have the Kasai within 90 days of treatment. And they were eligible to start the study within 3 weeks. There were a variety of inclusion criteria, basically in regard to confusing or ambiguous diagnosis and parameters outside of what would be considered pertinent for patients who would be going into the study. So there, we have such a great gratitude for the patients and families who embark on these studies with us, because as you've heard, it's a 1-to-1 randomization with placebo. And so it's just such an incredibly important and great gift that we get to be able to further understanding of this disease through the generosity of these patients and families. So the visits, as you see, there's a screening visit, there's a randomization visit, and then there's really every 13 weeks, there's a study visit to assess certain parameters and the efficacy and safety. At the end of 2 years, there's a rollover extension study where everybody will be on drug who was in the first part of the study. And then we have another optional extension study after that for any patients who are still in the program where the drug hasn't become commercially available to. And so, approval in Europe doesn't always mean you get access to the drug right away. So a lot of countries in Europe, there takes time to get the approval, get the reimbursement after the approval. And so any patients who have made the great sacrifice to be in our study, we commit to keep on drug until they can access the drug commercially. So here are some additional resources to get information about the study. As I said, the study has closed, and hopefully we'll be getting data on that within the next 2 years. Thank you very much for your time and attention, and I'll hand it back over to you, Farah.
Thank you so much, Dr. Clemson. We really appreciate your participation. I appreciate the participation of Albireo in our efforts. It's very important to us.
Thank you.
I just received a request from one of our audience asking if we could during presentation have the full screen to be the presentation so they can actually see it and read it. So for Dr. Narang's presentation, that's what we're going to do. Try to get the whole presentation on the screen. So it is now my pleasure to introduce Dr. George Yanni, who has generously accepted to be the MC and moderator for tonight's program. Dr. George Yanni, MD, FAA, SLD, is a professor of clinical pediatrics, Keck School of Medicine. He's associate director, pediatric liver transplant program, transplant hepatology fellowship director, Division of Pediatric, Gastroenterology, Hepatology, and Nutrition, Children's Hospital, Los Angeles. Dr. Yanni graduated from Ain Shams University College of Medicine, Cairo, Egypt. After completing his internship in pediatrics, he continued his residency and fellowship in pediatric gastroenterology at Kaiser Permanente Medical Center, Los Angeles, and University of California, Los Angeles, which we know as UCLA. In the past, Dr. Yanni has served as medical director and associate professor pediatric GI at Loma Linda University Children's Hospital and attending pediatric GI at Riverside County Regional Medical Center. Dr. Yanni's major areas of research and interest are pediatric liver disease, gastrointestinal and hepatic autoimmune disorders, transplant immunology, pediatric NAFLD, which is known as non-alcoholic fatty liver disease, and obesity, pediatric gastrointestinal procedures. Dr. Yanni, I know you're very busy, and I really appreciate you spending time with us and accepting to be our MC and moderator. Thank you so much. With that, I will give the mic and the screen to you, Dr. Yanni. I think Dr. Clemson is still connected because I see her name on the screen.
Farhan, thank you very much for this wonderful presentation, and thank you for a very successful educational year with the Liver Health Foundation. I'd like to welcome everyone, including our beautiful young ladies who are joining us today as a guest. It gives me a great pleasure to introduce to you a rising superstar in the field of pediatric liver disease, Dr. Amrita Narang. I have known Dr. Amrita Narang over the last 8 years since her first day when she came to Children's Hospital Los Angeles as a pediatric gastroenterology fellow. From the first hour, she indicated to everyone that the field of pediatric liver disease is going to be in a very safe and wonderful hands. Dr. Narang finished her fellowship with us at Children's Hospital Los Angeles in 2018. She finished her transplant hepatology fellowship with us. We have the pleasure and the blessing that she joined us. She completed her fellowship in 2019. Immediately, she started her attending career at world-renowned famous Stanford University in Northern California. Dr. Narang has a wonderful family with 2 handsome boys. Without any further ado, I will introduce to you Dr. Narang to talk to us about biliary atresia.
Thank you, Dr. Yanni, for that beautiful introduction. I will get started, but just wanted to make sure that you guys can all see the screen properly.
Yep, looks great.
Okay, perfect. Okay. Okay. Hi, my name's Amrita Narang. I'm one of the hepatologists at Stanford. My main area of focus is biliary atresia, and this is the disease that drew me to the world of liver transplantation. So here are the things that I'm going to be talking about today. We will talk about what is biliary atresia and what are its causes. How do we diagnose biliary atresia, and does the timing matter? How do we manage biliary atresia, the initial surgery, subsequent medical management, and finally liver transplantation. And throughout, I will briefly touch upon what is new in the field of BA. During today's talk, I'll use the words BA and biliary atresia interchangeably. Let's start with the basics. The liver makes bile, a yellow-green fluid, which helps digest the food, clear toxins, and ultimately gives color to our poop. The bile ducts are like a tree. The small branches within the liver are the intrahepatic bile ducts, and the tree trunk is the extrahepatic bile ducts that drain bile into the intestines. So what is biliary atresia? The first clear reference in the English language of biliary atresia was in 1817 by Professor John Burns at the University of Glasgow. It's a rare but serious liver disease affecting infants in which the bile ducts get damaged and eventually obliterated. There are two main components of this disease, the obstruction of bile flow and fibrosis of the liver. I'll refer back to this when we talk about treatment. Currently, there's no cure for this disease, and if left untreated, BA invariably leads to death from end-stage liver disease in the first 2 years of life. Even with surgical treatment, biliary atresia remains the most common cause of end-stage liver disease and the most frequent reason for liver transplantation in children. Despite the frequency and serious consequences of biliary atresia, the cause remains unknown. This is one of the main areas of research. What we do know is that it occurs more frequently and commonly in Asians and Africans, but it does not have any geographic clusters or locations. There is no evidence of it being genetic. It does not run in families and is not found in identical twins. The current theory is that infants with BA have a genetic susceptibility with these genes combined with an environmental insult, which leads to biliary injury and inflammation, and an abnormal healing process in which there is scarring and fibrosis of the bile ducts. There's been an important debate as to whether biliary atresia arises during fetal life or after birth. Findings suggest that biliary atresia is a disease of the fetus, which manifests only after delivery, with the loss of the protective physiology of the mother and the placenta. So what are the signs and symptoms? Children typically appear normal at birth. Jaundice may be present early, but it overlaps with the common physiologic jaundice seen in more than half of newborns. In children with BA, however, the jaundice persists and they soon develop dark urine and pale stools. As the liver disease gets worse, other problems arise, such as itching, big and distended abdomen, trouble gaining weight. In some countries, such as Japan, Taiwan, and Canada, babies are sent home with a stool color card to screen for biliary atresia, and this was started in Japan as early as 1994. How do you diagnose biliary atresia? That answer has also evolved over time. Blood work to check liver enzymes, ultrasound to look at the liver and the gallbladder, and a liver biopsy can be done. However, the gold standard is the cholangiogram, an intraoperative cholangiogram, which is where during a surgical operation, the extrahepatic bile ducts are examined, and then contrast is injected directly in the gallbladder to get the best look possible at the bile ducts. Once the diagnosis is confirmed, the surgeons proceed with the surgical treatment. Things that increase the likelihood of biliary atresia are elevated direct bilirubin at birth, which then rises to a level greater than 2 by 1 week of life, a small or an absent gallbladder, and bile duct proliferation and cholestasis on biopsy. Pale stools typically occur by the 2nd or the 3rd month of life. Research continues to progress and refine what we know, and there is more data about using blood biomarkers such as MMP7 and direct bilirubin screening within the first 2 days of life. I mentioned earlier that there are two parts of this disease, the biliary obstruction and the fibrosis. The biliary obstruction can be corrected by a Kasai procedure or a hepatic portoenterostomy. I will use these two words interchangeably. This has been one of the two most important advances in the management of biliary atresia. In 1955, almost 7 years ago, Dr. Morio Kasai successfully treated a 72-day-old girl in northern Japan. The extrahepatic biliary system was surgically removed, and a loop of intestine was directly connected to the liver. This led to restoration of the bile flow and relieved the obstruction. Over the next 30 years, the procedure was refined to prevent cholangitis. Improvements were made to post-operative management with antibiotics and ursodiol, and the team realized that earlier surgery is important for the success of Kasai. This led to an increase in the percentage of children with clearance of jaundice. So how early should a Kasai be done? This is data from one of the largest series of biliary atresia patients from France, which included over 1,400 patients. So if done within the first 45 days of life, it is associated with 65% survival with native liver at 2 years of age and 40% native liver survival at 15 years of age. Or in other words, if Kasai is done early and is successful, then the 10-year transplant-free survival can range from 75 to 90%. Japanese and Canadian studies have also shown that the best outcomes are in those who received Kasai at less than 30 days of life. Importantly, an early Kasai does not pose additional risks and is not associated with more complications compared with a Kasai in older babies. Since the timing of Kasai is one of the most important predictors in the success of the procedure, how do we diagnose biliary atresia early? Stool color cards can be used, but as I said, babies typically don't develop pale stools until 60 days of life. Also, it would require a central agency to triage calls from parents screening their infant stool at home in the US, and a 1-month standard pediatrician visit, which does not exist in the US. MMP7 is a blood biomarker, but it can also be elevated in other liver diseases. In 2011, Dr. Harpavat looked at 34 patients with biliary atresia and noted that all of them had a direct bilirubin level elevated within the first days of life, and it persisted and actually worsened by the 3rd day of life. Can this be used to screen for biliary atresia? He published again in JAMA in 2020 and showed that using a 2-stage screening process for biliary atresia using direct or conjugated bilirubin, in over 120,000 newborns, they were able to identify 7 patients with biliary atresia with a 100% sensitivity and a 99.9% specificity. It also led to decreasing the age of Kasai from 56 days before screening to 36 days after, and subsequent normalization of the bilirubin and clearance of jaundice at an increased rate. Larger studies are still needed to validate and evaluate the cost effectiveness of this approach. So now that we have potentially the capability of diagnosing biliary atresia, performing the Kasai within 30 days of life, is this enough? Unfortunately, the answer is no. Despite numerous attempts to improve the operative outcomes by modifications to the surgical techniques, the results of Kasai portoenterostomy remain unsatisfactory. About 60% of biliary atresia patients will achieve effective bile flow, which is defined as a total bilirubin level of less than 2 by 3 months post-Kasai. But there are plenty who do not. There are no clear indicators of which infants will have good bile flow and who will not. Some prognostic indicators that point towards good bile flow and prolonged native liver survival post-Kasai are a total bilirubin level less than 1, GGT less than 150, and the new kid on the block is serum bile acids. Blood measurements of bile acids are bile acids are the microscopic things that make up bile, thus a more specific marker of bile flow, better than the total bilirubin levels. What can we do to help after a Kasai portoenterostomy? Due to cholestasis and liver disease, patients with biliary atresia have increased energy requirements. Thus, it's essential to optimize their nutrition. This can be done with supplementing with MCT oil or lipogen while breastfeeding, or adding high MCT formulas like progestinol or elementum. After resolution of jaundice, growth impairments and higher energy needs usually normalize by 12 to 18 months of age. Long-term studies show that patients are able to achieve their expected adult height, and there's no compromise later on. Multivitamin deficiencies, especially with the fat-soluble multivitamins, are also very common and need to be supplemented. Studies have shown that children with biliary atresia are at increased risk for delayed language and motor skills, although it does resolve by 3 to 12 years of age. There's mixed data in terms of intelligence scores during school years. Cholangitis is a frequent complication after Kasai and more likely in patients who have not achieved good bile flow. Its frequency is highest during the first months and years after surgery. About 2/3 of the patients with native livers will have at least one episode of cholangitis by 10 years of age. Having cholangitis does not mean that the child will need a transplant. However, recurrent cholangitis is an indication for transplant. A study looking at adolescent patients who received a liver transplant in adulthood showed that cholangitis episodes during adolescence were associated with a 5-fold increased risk of needing a transplant when greater than 16 years of age. We've also started looking at health-related quality of life index in patients with biliary atresia, and the outcomes are variable. There was a large North American study that showed that the health-related quality of life was reduced amongst patients with biliary atresia with native liver compared to healthy children. However, it was similar to children who had received liver transplant. There's also another European study in 2020, which showed that the children with biliary atresia are at risk for impaired quality of life, and special attention is warranted for children with adverse medical events and special education. Even with achieving bile flow in about 60% of the children, the fibrosis and scarring of the liver may continue. This leads to development of chronic liver disease and portal hypertension. Portal hypertension is defined as presence of esophageal varices or splenomegaly with thrombocytopenia. Studies show that about half the patients with bile flow will have portal hypertension by 1 year of age and progress to about 2/3 of the patients having portal hypertension by 9 years of age. Other studies show that all patients who have biliary atresia and have not received a transplant will have portal hypertension by adulthood. Findings from the France study also show similar stuff. Thus, it's important that we continue to monitor for signs of progression of liver disease because it can generate major morbidity in both children and adults, and it requires frequent monitoring. As I alluded to earlier, there are 2 aspects of this disease: biliary obstruction that we attempt to fix with a Kasai procedure. However, the fibrosis can continue. Thus, the second most important advancement in the care of children with biliary atresia is liver transplantation. The bottom line is majority of children with biliary atresia will eventually need a transplant. The good news is the outcomes of patients after liver transplantation are great with over 90% survival. Until the time arrives in which we're able to understand the exact pathophysiology of biliary atresia and develop a primary cure, liver transplantation will remain a crucial treatment modality for this disease. So when is the right time for transplant? Children who do not demonstrate good bile flow and clearance of jaundice by 3 months post-Kasai should be evaluated early for transplantation, ideally by 6 to 9 months of age. There is controversy about whether children who get diagnosed later in life with biliary atresia, around 4 months, let's say, should they go directly to transplant and avoid the complications associated with Kasai or not? About 25% of the patients will have multiple episodes of cholangitis, and so recurrent cholangitis is an indication for transplant. Severe complications of portal hypertension, such as GI bleeding, malnutrition, and persistent ascites, should lead to a liver transplant evaluation. And lastly, hepatopulmonary syndrome. I think of hepatopulmonary syndrome as shunt or varices that develop in the lungs as opposed to in the esophagus. It leads to decreased oxygen levels and fatigue. It can occur in about 3 to 20% of children with cirrhosis and is diagnosed by an echo or an ultrasound of the heart or a lung perfusion scan. One of the key predictors of successful liver transplantation in children with biliary atresia is their nutritional status at the time of transplant. So if anyone is on the path of transplant, the best thing that we can do for them is to optimize their nutrition and make sure that they grow stronger. Currently, the mainstay of treatment for biliary atresia is surgical. However, I'm hopeful that with advances in medical management, there may be numerous medical therapies that may come to light. There are a few listed here that are undergoing investigation. And as we learned from Dr. Clemson earlier, there are 2 main trials ongoing today for odevixibat and maralixibat. As I personally learn more and grow in the space of taking care of children with biliary atresia, it's humbling to see how much we know and how much more there is to learn. Questions to address in the future research on biliary atresia include: can we have universal screening for biliary atresia? Can we identify patients who will respond favorably to Kasai? And can we have new therapeutic agents for those who will not? What accounts for the progressive hepatic dysfunction in patients and ultimately require a liver transplant? Thank you so much for this invitation to speak today by the Liver Health Foundation, and thank you so much for your time and attention.
Dr. Narang, thank you very much for this wonderful presentation about excellent educational materials. Without any further ado, and I know it's time getting for dinner, I would like to introduce our beautiful young ladies, the ones representing the 2 arms of the spectrum, as we say here. Molly Clark with her parents, Christina and James, and Morgan Faust with her parents, Erin and John. Welcome everyone to our roundtable discussion. And with this introduction, I'd like to ask Molly and her parents to give us a very brief, her successful story about being a fighter and achieving stability with her native liver.
Yeah, thanks for having us, everyone. James is over here. I guess this will be our story first, and then Molly can talk after this. So Molly was diagnosed with her biliary atresia at 6 weeks old. We knew that something was going on right around 24 hours old because she had jaundice. But luckily we had some good doctors on our side that were constantly checking her bilirubins and trying to understand what was happening. So then we got transferred to a different hospital that had a NICU, and they started to do some pretty extensive testing to see what was happening with her. But what was interesting for Molly is that her bilirubins actually started to stabilize a little bit. And then at some point we got to go home and monitor her over the next couple of weeks in and out of the hospital for different testing to understand if there was anything pretty common going on with her leading up to biliary atresia. Back and forth to the doctor, blood work almost every day. In fact, he's the one that did that. And interesting, we ended up at Children's Hospital because at the very end, they thought she might have cystic fibrosis. So we ended up at Children's for a cystic fibrosis sweat test.
And that was a Friday. And then the following Monday, we got the call that she did not have cystic fibrosis, but Children's was waiting for her to, for us to come down and bring her so she could have a liver biopsy the next day. So the following day on a Tuesday, she had her liver biopsy. And by Wednesday, we had the official diagnosis that she had biliary atresia. And in all of that time, you know, we were having conversations with various doctors and educating us on what it might be, what biliary atresia looks like, and how this the Kasai procedure goes, and lots of scary days, of course. By that Friday, she was in having her surgery at Children's with quite a few great physicians that they have there. And her procedure took about 8 hours. And when we got called into the office after her surgery, the doctor was Dr. Kawaguchi. She's fantastic. She was tearful because she was so excited that the surgery had gone so well. And they had noticed that Molly didn't have severe scarring already to her liver, which is probably why she's so healthy today, because it hadn't taken over so much for her. Dr. Rong had talked about 45 days being right around the ideal time, and we calculated it to be 42, I think.
Right.
We calculated it to be 42. So she is still living here with her liver, or her native liver. She'll be 13 at the end of this month. Our journey since her surgery has been, in my opinion, when you hear others, fairly easy. We praise God for that. She's been in the hospital twice. Dr. Yanni got to see us one of those times for possible infection. Come to find on the first one, she probably had something else going on, because pretty quickly she was, like, the next day, I think everything was kind of stabilized. Blood work was coming in good. So they sent us home after one day. But the next time we were there, that was about 2 years old. The next time we were there, she was about 5 or 6. And we were there for about 5 days, trying to understand, because at that point she actually had a fever and some other symptoms, but then also pain at her liver site or in her belly. And then again found that it may or may not have been cholangitis. In fact, Dr. Yanni had made some comments about the chances of her having cholangitis, if she had never had it at 6 years old, may have been pretty slim. So we ended up being able to go home, and she was put on oral antibiotics for 6 months. And she's been super healthy. We were seeing a doctor who had her on, remind me the name of the, Ursidile. She was on that until about 6 or 7 years old, would you say? Yeah, 6 or 7 years old. And then Dr. Coley, who we see at Children's Hospital, said that Molly was doing so well and her numbers have been stabilized for so long, so let's take her off of it and see how she responds. And if her bile still produces just fine, then that means she's doing okay. And to this day she is. And she continues to have yearly checkups where she goes in for, a pretty extensive ultrasound, and she does blood work twice a year, which she's unfortunately gotten used to. That was not her favorite thing for a long time. And then we also do a probing, I don't know exactly what it's called, but a probe type procedure or testing on her to determine, how hard and big and small and whatnot her liver and her spleen are, I believe. And so Molly, she can tell you about what she does these days. She's pretty much, in my opinion, a normal 12, almost 13-year-old. So what does your life look like, Molly?
Well, I've been doing lots of basketball lately, which is very fun. And I just started doing volleyball again, which I'm really liking. And I like to hang out with my friends, and I love to make bracelets. I think that's so fun. And I like to play with my dog and watch movies.
So, and she, naturally talks to her friends and, the people around her who know about what's going on with her. She'll share her story, and those that are newer into our life will all of a sudden see something on Instagram or Facebook where we're posting Molly's, speaking at an event like this or raising money for awareness. And so then they'll ask us the question. So that gives us the opportunity to then share our story. And I think, Molly, you were just at school recently and they asked you to tell them something that they didn't know about you.
Yeah, one of my teachers, she does question of the day, and the question was, tell me something that I don't know about you. And it's like you have a little paper and you write it down, and I wrote my whole story about it, and she really liked it.
Thank you very much, our beautiful superstar. Thank you for being a fighter, and happy early birthday.
Thank you.
So I'll turn the microphone now to Morgan and Arian Johns. I know that this is a totally different story from your from your side. Arian, can you tell us what prompted you that Morgan, there's something not really going on the right direction for her?
I was oblivious, in all honesty. We went in just for a regular 2-month pediatric, the checkup for the babies. I actually had 2 of my best friends. They were at the house. I'm like, hey, I'm going to run down to the pediatrician who lived, or his office was literally right down the street. So John was at work. I think I had my mom come with me. John and I were just discussing this. And Dr. Taylor came and he took one look at Morgan. And the expression on his face just changed. And he's like, something's not right. And Morgan had this gorgeous olive color skin. And I thought it was some sort of family lineage from, my background, because I've got olive skin, but hers was like legitimately green olive. And I look at pictures now and I'm like, yeah, that's not normal. We didn't know. When we left the hospital after she was born, she had pink, rosy cheeks. She didn't have any jaundice. Or did she? I don't really even remember. It was
one of those situations where they almost questioned it. That does she have jaundice? Does she not have jaundice? And it was never enough to where they said, let's give the test. So that skated through in the initial birth.
We had full term. In fact, both my kids were 9 days late, so we didn't have any of those complications. Early on in the pregnancy, maybe it's 6 months, they noticed some calcification on her heart. So we went in and did the amnio and like, no, but they were checking for something else. But at 2 months, like we need to run some tests. And this was on a Friday. That afternoon, we found out that they would have a bed for her on Monday. And I just remember asking the doctor, I'm like, is my baby in mortal danger? And he said, yes. So I had to call John, who was up in Long Beach who was working up there. So he races down to Long Beach and he's there for what we have no idea. Like we had no clue what was going on. And he was trying to explain some things. And, so taking it all in, and we had 48 hours to try to figure out, not what we were going to do. I mean, the medical world is the medical world and they know a lot more than I do. And so we just kind of had to turn it over to Chalk, and they wheeled us in and everything just kind of spiraled from there. We were told that, that she was going to have the Kasai, and they went in and they did all the same tests that they would have done for Molly. And I don't remember half of it. I mean, honestly, I just don't remember. But they told us that, a successful Kasai would take 3 to 4 hours. My parents were there. John's mom had flown in from Arkansas. We were all there, and 3 hours passed and things were going well. That's all we knew. 4 hours, 5 hours, 6 hours, finally 8 hours. And Dr. Kabir was our surgeon. And the reason it took him so long is he was trying to find the right, do you remember? I forget the term.
I don't remember, valves or something.
Yeah, whatever it was.
Material.
But he had a super fat one that he was able to connect to Morgan. And in fact, when she had her transplant a couple of years, they used the exact same bile duct. I don't know what it was, but whatever it was, that's what they connected the new liver to. So, her story's a little bit different. She was not in and out of the hospital. We went back because she, ascites kicked in about 2 months later. So we had to go in and have a Lasix and brought her down. During her initial, during the Kasai, one of the learning doctors, I can't remember the student doctors, whatever, residents, found an abnormality in her heart, in her heartbeat. So they went ahead and checked that out. Turns out she had a coarctation. So at 6 months, we went in for heart surgery. That visit was a lot shorter. We went from a 21-day with the Kasai to a 4-day with the heart surgery. Came out and we're doing well. We were on kind of routine. Oh, I froze there for a minute.
Yeah, I think we froze.
Routine stuff. We were visiting our GI doctor, Dr. Ho, every 3 months, and things were stabilizing. I don't think we went in for a while after that.
Yeah.
Erin, what is the time frame between the Kasai and the first sign that she's starting to notice that there is something, this liver is acting up again? So she stayed stable all these years?
She always had a little bit of ascites. Her spleen definitely started going into overdrive. When she started elementary school, she hadn't had an issue with her liver, so we would do some of the annual, the checkups with the ultrasounds and those sorts of things. Elementary school, we just had to let the teachers know, hey, she may have to go to the bathroom because things aren't working 100% right. She might fill up. Don't worry about it. We've got her under control. So we were not, I don't think we were in and out of the hospital a lot, shy of being a traditional child.
No, every couple of years, and then towards the end, when we got closer to the transplant that we were in at 7.
Yeah.
And then shortly, a little over a year later, we went back in, and that's when all the transplant.
Yeah, she spent her 7th birthday in the hospital, and we were at school, and she just wasn't feeling well. She had spiked a fever. We went in midweek, and they're like, yeah, cholangitis possibly. We were there for 10 days. She went in weighing 40 pounds, and they pump you full of a bunch of fluids when you got a fever, and she just packed it on. So she had 10 pounds of belly weight, just fluid weight on her. And that was hard. I mean, to see your 7-year-old who looked like she could be 6 months pregnant, just the physicality of it. But 10 days later.
Sorry to interrupt you, Erin, but when is the time the liver transplant was introduced to you? Like was all this time when she has ascites, like nobody talked with you about?
No, they did.
Day one.
They did. I apologize. John and I, we handpicked our GI doctor who was not forcing us to jump to that immediately. We kind of went in with if it ain't broke, let's not fix it. We didn't get out ahead of it too soon because I didn't want our life to revolve around unnecessary things too soon, if that makes sense. We actually pushed one GI doctor, kind of said, we don't need to see her because she was definitely pushing for us. Hey, let's go in, let's go do this. UCLA is not an easy drive for us. And the idea of having to go up there 2 or 3 times a year, selfishly, was not conducive. We're in Orange County. It had been introduced, but our doctor was very patient with us. He's like, hey, what? She's stable. We won't. Not until you guys are ready or until we really see that things are taking a turn in that direction.
And we went up to meet the good folks at UCLA when she turned 7?
She was 7 and a half. Yeah.
And then we got introduced to everybody, and we were about to get up there, and they were going to remove her really from the active transplant potential list because she was doing so well. And that is when we actually ended up with the cholangitis and
The second time. Yeah.
bumped up to the top of the list.
Yeah, her story, we were supposed to go in for a checkup. COVID hit, they bumped us, and we're like, okay, we went on family vacation, came home. Honestly, God, we thought that she'd come into some sort of farm animal disease because we'd just been on a ranch. First time I remember her actually being yellow. She had been green as a baby. And I had John come out and look at her. I'm like, her skin actually looks yellow. And we kind of hummed and hawed. I'm like, well, she's had a fever. Okay. Went ahead, went up to Chalk, got checked in. She had been fever free for 24 hours without Motrin. And then I swear the second we stepped in, her fever spiked again. We were there for a week. Again, she ballooned up. We LASIKed, came down. We were getting ready to come home. Literally the next morning. So at 2:00 in the morning, Mommy, I don't feel so good. And I'm like, what's up? And next thing I know, she's throwing up. She had, we all know the hospital desserts, but she'd had some sort of chocolate pudding. It's 2:00 in the morning. I don't see anything. And then I'm like, oh, she's throwing up her pudding. No, then we turned on the light. That poor kid, her varices had burst and she threw up about 200 cc's of blood. That ran us right back up to the ICU, and they transported her to UCLA the next morning. This was a little bit of a shock for all of us because we thought we were coming home. And, prior to that, like John said, we were being taken off the active transplant list. We get up to UCLA, they banded her varices, and, we were there for, I think, another 2 weeks while they were running tests. She'd had 2 or 3 offers where she was the second one on the list. And that's when we were told, yeah, this is happening. This is going to happen within the next, I want to say 90 days. This was in August of 2020. And, school's starting. John and I are both teachers. Fortunately, my district was doing online. John was working in online schools. So we're like, okay, I guess our kids are doing online. We had been called up over Labor Day. School was supposed to start on Wednesday. Morgan at this point is like, is that my new liver? Like she was a rock star. I mean, this kid, she was having nosebleeds continuously, was handling them on her own. We get the first call, we go up there, and then the first rejection, like the liver's too big. It was evidently from a 10-year-old, but size discrepancy. And we found out that liver went to a 22-year-old man. So we came home. During my time up there staying with Morgan, one of the options is to be a living donor. So both John and I were going through the process. I had everything cleared because I was there and I could do the test, and John was trying to do what he could from home. We got sent home, and basically we're told, we'll call you. Okay. So we get the first call, nothing. You live with your phone. You don't go more than 5 miles from your house because you're literally on call. And, we started the school year. Things, kind of got off and running. My classes, Morgan was doing online school. Her younger sister was doing online school. And right before Peyton's 6th birthday.
Yes.
The week before, we get a call. So we go up there. It was a Friday. They were going to do a split liver for her. Again, Morgan and I come home Friday. I go up the following Monday to go run through my stress tests. Because at this point in time, our 90 days is closing in. And I even told our doctor, I was like, if I'm good to go, let's do this. I don't want this to be a life or death transplant. I wanted to save my kid. And 24 hours after I was given the all clear, we get called up a third time. And I remember looking at John going, I can't handle a third rejection. We were there. Our babysitter had flown from Massachusetts to stay with our younger one. We went up there, and that was a long day. But at 5 o'clock, they came in and told us it was a go.
Well, that's great story, Erin. I know you and John through a lot, but thankfully, that's right now you have a beautiful, young, healthy patient with you. I know this is experience like you went through right and left between her liver, her heart, and all these um, uh, like rocky roads. I just would like to ask Dr. Narang, what do you think, Dr. Narang, about this presentation about we have Molly, which is thankfully and God willingly to continue thriving with her fighting and achieving, and Molly and Morgan, which like went through this rocky road. Do you think that something could be like intervened in between this to avoid this frustration for the family?
I think this kind of both the stories have kind of shown the nature of the disease, where there are some patients who, some patients are doing beautifully and do well with their native liver, and then there are some like Morgan who need a new liver. And unfortunately, as I was saying in my talk, that we don't really have a good way to figure out who is going to be in which category, in which bucket. If we ideally knew who's going to progress how, we could potentially intervene sooner and do something sooner. The other question that Dr. Yanni asked was, could we have done something different? And that also is sort of how the scoring system for transplantation works. Right? We need someone to be sick enough to get a higher score, and we know that our PELD score, which is what we use for transplant, is not a great marker in kiddos with biliary atresia. And so we ask for extra points. We do everything else that we can do. We do have medications to manage symptoms, but as you mentioned, there are GI bleeds that happen. There's ascites that happens, and so I think just being as great of parents as you can be, to keep a really close eye, good watch on the kiddos to manage them. But it is a very challenging disease, as you mentioned.
Yeah, I would like to ask Morgan how she feels.
How do you feel?
Morgan, how do you feel?
Fine. I just have a stuffy nose.
You have a little cold,
In general.
but in general, are you feeling well?
Yeah.
Yeah.
Morgan,
Yeah,
we heard
when
a
I
little.
s-
We
I
heard a
tell
little
you-
bit from Mom about this. Tell us your story. How was it?
How was the transplant surgery?
Peyton, stop it. It was okay.
She was excited. I'm gonna jump in here. I mean, she was 8.5, and just we kept it real cursory for you, like, hey kiddo, your liver's not doing so well. We're not gonna bore her. It was that was John's and my burden. Is you're a kid, you're not gonna worry about this. Let us handle it. And we just talked like, hey, you're getting regular nosebleeds. If we get you a new liver, that means the blood can go through it. And one of the things that I think speaks volume of Morgan is we kind of explained where the liver would come from. And I remember one time she looked at me, she's like, Mommy, I don't want somebody else to die from me. Can I just have yours? I said, baby, if that's what we need to do, absolutely. But she was getting excited when the calls would come. She's like, Mommy, is that my liver call? Do I get a new liver? And we'd go up there, and then we'd come down like, not this one, kiddo. We're just trying to keep her spirits high. I think that's been probably one of our greatest strengths, is to not show our worry. We're the parents. That's our job. You be a kid.
Yeah.
You don't worry about it. And her younger sister, I don't want to segue too far, but her, Peyton watched Morgan go through all this. And I think 2 months after Morgan's transplant, we learned that Peyton needed a partial tonsillectomy. And I'm just going to throw this in there because it just shows the strength of this kid. Peyton goes through, has her tonsils shaved down. She's coming out of the anesthesia and she's like, Mommy, did I get my new liver? And, I mean, that's what Morgan just rocked through it. She's coming home. She, the neighbors were out there. She came home after 21 days, I think, post-transplant. Neighborhood's out there and they're like, yeah, Morgan, go. She comes in, she lifts up her shirt, she shows everybody her scar, and you can look in their face like, wow, she's 8.
Yeah.
Well,
I'm a grown man who could go through what she's gone through. She was riding a bike the next day, and Dr. Venick was not real happy that she's got the needle stuck in her arm. I forget what it is. I don't remember. But she had it for the PICC line thing. She's like, maybe we don't do that in case she falls off her bike. Like, you want to break that news to her? Because the kid wants to ride her bike, and we're gonna let her pretty much do whatever she wants. So
thank you very much for being the advocate for Morgan and Molly, beautiful young ladies here, and hopefully to have you all the time with us for the upcoming years for this educational. Thank you, Erin. Thank you, John. Thanks, Christina. And thanks, James, for participating. Thanks, Farah, for this wonderful educational evening, and wishing you all a happy holiday. I'll hand this back now to Farah.
Thank you. This was wonderful program. Thank you. Our heartfelt appreciation to Molly, Christina, and James, and also to Morgan, Erin, and John. And I'm hoping that this story will help a lot of other kids who are living with BA, and hopefully in next year we're going to do a lot more with rare pediatric liver diseases. And I really would love for both of you ladies to be our spokesperson and talk to other kids for us, because this is important. I also want to thank Dr. Narang for her beautiful and great presentation. Dr. Yanni, thank you for your time and for your generosity to accept to be our moderator. With your permission, I would say a couple of things about our upcoming 2023 programs. We will, of course, have our walks, our educational webinar like this, and we will do seminars anytime we can, and it's safe for our patients. But right now, I want to talk about 2 in-person events, walk in Orange County, and Morgan and Erin and John, I hope to see you there, March 11th. Please mark your calendar. And September 23rd is a walk in Los Angeles, and I know Molly and Christina and James will be there along with our other walkers. Also, the other 23 program I want to talk about is Salute to Excellence Dinner Gala, which Dr. Yanni talked about a little bit. We will do this every year. Next year, it's going to be in October 23rd. And again, we will honor some of the best hepatologists, liver surgeons, community leaders, nurses, and liver patients. This year, Molly was our liver star and did a wonderful job. I also don't want to forget to thank Dr. Clemson and Alberio for their wonderful support all year for us. They have been really lifesavers, and they have been helping us. They have helped me reach to a lot of liver patients. Thank you, Alberio. The last reminder is please see us and like us on our social media sites. We are on all social media, including Facebook and Instagram and LinkedIn. So please visit us. And don't forget to visit our website that will have the list and information about our upcoming events, liverhealthfoundations.org. So I thank all of you for your participation tonight. I hope our patients found this webinar helpful. And then I want to, on behalf of Liver Health Foundation's staff, medical advisory council members, board of directors, our presenters and guests tonight, I wish you all a happy, healthy, and safe holiday season. Until we see you again in 2023, please be safe and stay healthy. Good night.